Welcome back. You're still with the agenda. Now, the South African Constitutional Bill of Rights says that everyone has a right to have access to healthcare services. However, experts say the poor bear the brunt of the inefficiency that comes with a public system that serves the vast majority of the population. They say it is chronically underfunded and understaffed. Now, the wealthiest 20% of the population use the private system and are far better served. In South Africa, private and public healthcare systems exist in parallel. And today we dissect South Africa's public and private healthcare systems. From our Durban studios, we have Dr Anaban Pillay from the National Department of Health and Professor Sylvester Chima, an academic in the field of medical ethics, medical law, as well as human rights. So we did invite Section 27 and the union NEHAWU to join us, but unfortunately they both pulled out at the last minute. So gentlemen, thank you very much indeed for your time joining us there in Durban. Dr. Pillay, if I may start with you, I mean, the health minister did say that the system is very distressed and going through some tough times. What's your opinion? What's the current situation?
Yes, the health system, both in the public and private health system, have a number of challenges. The public health system has the challenge of quality in terms of the services that people access at health facilities. The private health system, on the other hand, has the challenge of the high cost of care. So in the public system, much of the challenges relate to waiting times, the attitude of staff and cleanliness in facilities. Whereas in the private health sector, people are experiencing very high costs of care, particularly extremely high medical scheme premiums, co-payments, and the like.
You know, if we focus on one particular issue, which is oncology, that seemingly there was a crisis in particular in KwaZulu-Natal. What is the current situation with regards to cancer care? Has it been resuscitated?
Yes, the oncology challenge that KwaZulu-Natal was experiencing was twofold. One related to the oncology equipment or the machines that are used for radiation, which had broken down and could not be used to deliver radiation therapy at one of the hospitals. And the second problem that they experienced was that the movement out of the public sector of a number of oncologists. We've been able to solve both those problems, both by procuring additional oncology equipment, and we've had to bring in oncologists through the Wits Health Consortium to assist the province to do so. We're also looking at the more medium to long-term plan of making sure that oncologists are employed and trained in the province and remain within the public health system so that they can serve the public health population.
So, Doctor, what does it boil down to? Does it boil down to inadequate human resources and as well as procurement and financial management issues?
Well, it relates to four areas particularly. The one area is, as you mentioned, human resources. The second area is about management and the whole controls within the system. The third relates to financial management, and the fourth relates to infrastructure and equipment and the like. So those are the four areas that we have identified across several provinces where problems in healthcare exist, and being able to fix those problems are part of our challenges before we actually implement the NHI.
Yeah, I was just about to say, is this a reflection of national competence issues? And, you know, we're bringing in the NHI now. We're in that process. The bill has been launched, gazetted. How would this help?
Well, the bill introduces what we call a purchaser-provider split. Under a purchaser-provider split, the funding that is allocated to a provincial health facility or a private health facility is linked to the type of patients that the facility treats. In the current arrangement, facilities receive their funding irrespective of the number of patients that come through the door in the public health facility and irrespective of the quality of services that are provided. Under the NHI, both these, the number of patients, their acuity, as well as the quality of services, will be managed very differently using the Office of Health Standards Compliance as a key measure of identifying which facilities will be able to deliver services, what services they can deliver, and what will be paid for those services. So the patient will have a central role in identifying the facilities of appropriate quality, because those are the facilities that they would go to, and the funds will follow such patients to those facilities.
Okay. I want to touch on more about the NHI and how does it work, and I will bring in Professor Sylvester Chima in a little while. But let's take a bit of a break. We'll continue this conversation afterwards. Stay with us.